Hi, everyone. This is Tiffany Treadway, Comms Officer for Willowhead. We do apologize for the technical difficulties that just transpired. We're not sure what happened, but we will wait for our Bureau Director, Avis Richard, to rejoin us as she renders our welcome for this afternoon. Thank you. We're kindly asking if you are not presenting, please mute your microphones. Thank you. All right, and there she is. Again, we apologize for the technical difficulties this afternoon. Now we will hear from our Bureau Director, Ms. Avis Richard.
Okay, well, technology, we love it, but sometimes it turns on us, but that's okay. We're all back together again. So again, good afternoon, everyone. And thank you for joining us today. I am Avis, the Bureau Director for the Bureau of Chronic Disease Prevention and Healthcare Access. As Tiffany did share with us, we are branded as Willowhead, Louisiana. And today we are continuing our chronic disease series and have with us two phenomenal speakers who will share with us why screenings and follow-up on annual well visits are so important. If you have a combination of, let's say, headaches or fluid retention or tightness around your chest, we're going to hear from Dr. Leah Cullins, who's with our Willowhead program, and she is a PhD advanced practice nurse. She will walk us through what these types of symptoms may mean and indicate for high blood pressure. And of course, we all know and have heard from our physicians or primary care provider how recommended annual health screenings are so important. And today we have with us Carly Bodwin with the Louisiana Breast and Cervical Health Program. And she will share with us more about her organization and the importance of screenings for breast and cervical health. I'll turn it back over to you, Ms. Tiffany.
Thank you, Ms. Avis. Without further ado, let's hear from our very first keynote speaker this afternoon, Dr. Leah Cullins. Dr. Cullins has been actively involved in the care of clients with HIV infections since 2008, where she diagnoses, treats, and educates these patients. She obtained certification for HIV quick testing in 2007. She has lectured and presented on HIV/AIDS and nursing implications nationally. Her research interests include disparities, physical and psychosocial responses to HIV/AIDS, disease, and also HIV prevention and education. Dr. Cullins has been sub-primary investigator on over 30 pharmaceutical clinical trials in which she actively published on. Many of these drugs are currently used worldwide. Dr. Cullins has published her research in a plethora of medical journals and textbooks. A well-recognized healthcare provider, community activist, and change agent, Dr. Cullins is the founding chartering president of the chartering chapter of the 100 Black Women of the Metropolitan Baton Rouge, a member of Junior League of Baton Rouge, a member of Chi Eta Phi Nursing Sorority, a member of Alpha Kappa Alpha Sorority Incorporated, the La Capital chapter of the Links Incorporated, and Sigma Theta Tau International Nursing Sorority. As a medical professional, she continues to proudly speak on the strides and accomplishments that Baton Rouge has made in the area of community health care. Without further ado, let's hear from Dr. Leah Cullins.
Good afternoon. Next slide, please, Tiffany. So I'm just going to do a little bit. Next slide, we're going to do a background of information. Next slide. So, okay. So why the emphasis on women's health? Okay. So I'm going to start off just saying women make healthcare decisions for the family. They're primarily the healthcare decision making in their household, right? Women spend healthcare dollars on healthcare. Women are the role models for each of the family members, and 2/3 of the women are solely responsible for family healthcare decisions, access to healthcare. Next slide. Okay, access to healthcare services is a problem for many. So the barriers by gender. So we have had healthcare problems in the past and you just see the doctor, but did not. We have 27 to 21% women versus male. 14% of women unable to see the specialist when needed, and 22% of the women could not afford to fill the prescription. And it also goes with refills as well. So sometimes women tend to just go without. Next slide, Tiffany. So let me give you an overview of the women's health statistics. The number of residents who age 15.8% of women age greater than 18 age over, they currently smoke. 36% of women age greater than 20 are obese. 33% of women age 35 older have hypertension, and 68% of women age 40 and older had a mammogram in the past 2 years. And we know that the starting point for women to get mammograms is 40 and plus, and if you have a family history, it's 35 plus. 75% of women age greater than 18 has had a pap smear in the past year, and we know that pap smears are recommended for 18 and older every year, not within the last 3 years. Next slide. Women's age. Next one. Okay, so the U.S. Women Health Statistics. This is national data. The leading causes of death are heart disease, cancer, and stroke. Next slide. So let's talk about hypertension. Hypertension falls under with heart disease, correct? So for hypertension accounts for 1 in 5 deaths of U.S. women and is a greater burden for women than men. More women than men with hypertension develop adverse pathophysiological consequences such as left ventricular hypertrophy, diastolic dysfunction, heart failure, which Ms. Avis discussed earlier, with or without preserved ejection fraction, meaning how much the blood pumps out throughout your heart. Increased arterial stiffness, meaning your arteries starts to stiffen up, meaning the blood cannot flow properly through your heart. Diabetes and chronic kidney disease, which leads to dialysis in our women. Next slide, please. Hypertension with prior cardiovascular disease, such as a coronary artery disease, is the most prevalent dyad among female Medicare beneficiaries. Control of hypertension reduces cardiovascular disease-related adverse outcomes. So if you can control your hypertension, if women can control the hypertension, then the cardiovascular-related disease won't be as bad. When it's not treated, it contributes to poor quality of life, disability, and health care resource consumption. Next slide, I'm sorry. Among adult Americans, hypertension occurs in more women than men. After age 60 years, the prevalence becomes higher in women than men, and this gap widens with aging related to the large proportion of older women, possibly medication access, and ethnicity concerns. Hypertension control rates appear higher in women than men, greater and equal to 18 years of age. In those age greater than 60 years and older, controlling women is less than in men. So you see that women are losing the battle on the fight for hypertension with these statistics, right? Yet debate remains because optimal blood pressure targets have not been established to the highest level of evidence, particularly for older women. Next slide, please. Primary prevention of hypertension in women. Coronary health disease, which is CVD, is the leading cause of death for women. And it's the most serious neglected health problem for women in both developing and developed worlds. Hypertension among is the most important factor for developing cardiovascular disease in women. Number one cause of cardiovascular disease in women. If you don't take anything from this, just realize hypertension causes heart disease in women. Older women are more likely to have physical comorbidities such as hypertension, comorbidities such as diabetes, comorbidities such as physical inactivity. Based on, it's supposed to say 2021 to 2024 data, 46% of adult Americans age 18 or older have hypertension, which is defined as a systolic blood pressure greater than, equal than or greater than 130 over hypertension over 80. So we're looking at 130 and 80 and higher to give the diagnosis of hypertension. This translates into greater than 103 Americans with hypertension, of which 82 million would be recommended for antihypertensive medications, and this prevalence increases with age. Next slide. This translates to 50 million women with hypertension, of which over 41 million are recommended for antihypertensive medications. That's a lot. Among adult Americans taking antihypertensive medication with blood pressure treatment goals recommended by the 2017 American Cardiology Association, 50% are women versus 52% being men. And these fractions are highest among people of color, African Americans, Asian Americans, and Hispanic Americans. Next slide. So, blood pressure. What are normal blood parameters? Prehypertension and hypertension. Okay, next slide. It stated early in this previous slide before this one, we said that hypertension is diagnosed as greater than 130 over 80, equal to 130 over 80 or greater than 130 or over 80. So hypertension can cause brain disease, stroke, or dementia. Hypertension is known as the silent killer, right? Some women don't even know they're functioning with high blood pressure. They're constantly going, the weight on their shoulders, right? Maybe I just have a headache, or maybe I'm just getting a little shortness of breath. Maybe I'm retaining this fluid, but maybe that's because I'm eating too much salt. When in actuality, is they're experiencing hypertension and it's misdiagnosed or undiagnosed in a lot of cases until a heart attack happens. So hypertension can cause brain, stroke, dementia. In the heart, it can cause coronary artery disease, heart attack, congestive heart failure. In the arteries, artery damaging and narrowing, which leads to heart caths and stents and pumps. It can cause aneurysms and it can cause leg amputations. Like what we see a lot now, especially in Louisiana, hypertension will lead to kidney failure or kidney artery aneurysm. And once we see, you can see a lot of, you guys notice a lot of dialysis clinics have been popping up around more in the state. Everywhere you're just seeing a lot of more dialysis centers. Why? Because hypertension affects the kidney so bad. So they, in turn, they're blown anything. So the filtering of their kidneys. So that now we have to get on dialysis. Next slide. So why focus on hypertension treatment? Number one, it is affordable. It's really not that expensive, especially when you first starting off with hypertension. They tend to put you on something called hydrochlorothiazide. That's a medication, right? And it's not that expensive. With insurance, with Medicaid, it's $1 for 30 days. And with private insurance, it varies, but it doesn't go over $5 to $6, right? It's simple, okay? You come in for a couple blood pressure readings, you were diagnosed with hypertension, we write you a prescription for hydrochlorothiazide, and then we follow you from there. We may or may add another drug to it, we may or may not. We will educate you on changing your lifestyle, decreasing the sodium intake, exercising, visiting your doctor on a regular basis, okay? And it's essential. If you don't treat hypertension in the beginning stage, it's going to advance, and then it'll lead to the things we said on the previous side: cardiovascular disease, dementia, heart, stroke, heart attacks, and eventually lead to dialysis placement. Treatment of hypertension in primary care can save more lives than any other primary care treatment program. Next slide, please, Tiffany. So staying healthy, like I said, how can we stay healthy? Okay, and stay away from getting the hypertensive diagnosis. And if we do get the hypertensive diagnosis, what can we do to help combat that? So we don't lead to the hearts, the strokes, the dialysis, the kidney funks, the amputations. Balanced diet. Make sure you're eating a proper diet. Decrease your salt. I always say decrease your salt. Do not add all exogenous salt. Proper exercise. How many of us are exercising on a daily basis? In that 30 minutes of aerobic exercise or cardiovascular exercise every day. Proper exercise. Another means of exercise. You know, a lot of people like to walk, some of us like to jog. What I've been finding now, research has been shown in the last year and a half. This started off during COVID, this research, an exercise called rebounding. What rebounding is, it's a small treadmill, right? Not treadmill, I'm sorry, it's a small trampoline. Kind of like the ones you put in the yard for your kids, but it's a small one for the house. And it has a bar. And you jump on it, and you jump on it, and you jump on it. And that is considered one of the best exercises that they discovered since COVID. And being a person that uses rebounding myself, it really does help with everything cellular. So we got the balanced diet, we got the proper exercise, making sure you get adequate sleep on a regular basis, because Not getting adequate sleep can increase your stress levels, which can in turn increase your blood pressure levels. So it all goes together: sleep, exercise, diet, rest. Immunizations. Make sure you're up to date on your immunizations. We always want to advocate for professional screenings. Yes, you can go into the CVS and stick your arm in the machine and get your blood pressure reading, but to be 100% accurate, you want to go to your healthcare provider, whether it's your doctor, your PA, or your nurse practitioner like myself, and get a one-on-one blood pressure screening. And some people do suffer from white coat syndrome, where they don't have high blood pressure, but when they get into the doctor's office, they feel anxiety and they get high blood pressure. And then they leave and it's no longer there. But then that's where writing down your blood pressures in a journal comes in handy to bring to your healthcare professional. Mental health. We all know that mental health causes a lot of problems. And if you're not well mentally, you can't be well holistically, which I believe in. To have a healthy body, you have to have a healthy mind. So to approach this health holistically, take your meditation time. During lunch break and you had a stressful day at work, take your lunch break, sit in your car, debrief. Go walk around the neighborhood if you work remote. If not, walk around downstairs, outside your building, something to get your mind at ease, because mind, body, and spirit equals holistic care equals lower blood pressure, because you're not as stressed. Every day we come to work, yes, there is some kind of stress, but there's also some kind of way that you can combat it. You do not have to be a victim to this disease or any disease, therefore. Next slide, please. Height and weight. I don't know why it didn't come up. Maybe something on my end. Height and weight. Look up for yourself. Okay, what is the perfect weight for your height? And stay well within those parameters. And even if you can, go a little lower than those parameters. Don't just be right at the cusp of it. Because a healthy weight shows that I have patients who they lose 5 pounds and their blood pressure immediately goes down. They lose 10 and immediately goes down. All that plays a part in. Next slide, please. For cholesterol. Okay, so I didn't leave a number. I said women over such age should be checked. I believe it's no certain age a woman needs to be checked for cholesterol. She needs to be checked every time she goes to see what her cholesterol is, to see what's going on in her vessels, to see if we maybe need to put her on some kind of anti-cholesterol medication, or like I said, changing your diet, increasing leafy green vegetables, whole grains into your diet. All that decreases your cholesterol. Before I would want to put you on a statin or something to lower your cholesterol, I would want to put you on something natural first. We're going to change your diet. We're going to add whole grains. We're going to add some more fresh fruit. I'm going to add some leafy green vegetables for your cholesterol to decrease your blood pressure. Next slide. All right. So a woman's health is a reflection of her family genetics, which, some things, my mom had high blood pressure, my dad had high blood pressure, I'm going to have high blood pressure. That may be true to a certain extent, but you can always fight your genes. So if your mom had high blood pressure, your dad had high blood pressure, and everybody in your family had high blood pressure. But what about me that I can do to let that in my generation? I can exercise more. The researchers show for every 3 hours that you exercise, you add an hour on to your life. So let's become active. Let's start walking, running. You can't run, jog. You can't skip. Do some kind of exercise. And actually, rebounding is really good for people who have joint issues, because you're kind of going against gravity, joint up and down, and shaking the cells up. Women's health is a reflection of her culture, social norms, economic status. Something I say all the time. How can I expect one of my patients who's a mother of 4, single, to totally be fully into her health when she has so many kids to take care of? It also has to do with socioeconomic status. How can I tell this woman not to, if it comes to buying a box of chicken to take care of her family, to eat for that day versus buy a cup of fruit, which is basically the same in price, right? What can I do to teach her? Okay, the chicken, okay, you can't not buy the food. So let's see what we can do. Let's peel the skin off the chicken. Let's peel that fried off and you just eat the meat. No, you don't need that biscuit. Things that we can do to encourage ourselves, because it's easy to say, hey, cut all that out, go to Whole Foods, buy fresh fruits and vegetables, so on and so forth. When in reality, her socioeconomic status may not allow her to do that, but we can adjust it according to her socioeconomic status. physical environment. Stress plays a big role in hypertension. Like I said, exercise, meditate, rebound, jog, skip, play tennis if your knee's bad, but just get into something active to get your heart pumping, to get your blood flowing, and daily actions and thoughts. And I'm coming to the end of my presentation, but just thinking positive. And I know everybody, oh, here she go with this, the positive thinking. But thinking positive will manifest positivity. Okay, that's something. I'm a healthcare provider, and I practice, and I see this all the time. Don't think about the disease process. Think about overcoming the disease process. I encourage that, and that goes back to the whole holistic thing: mind, body, soul, complete wellness. Next slide. Okay, so some differences in women's health care. And I think I have 3 more minutes, Miss Tiffany, before I can let Miss Kaylee start. So I'm just gonna make it fast, and I just hope that I have explained things about hypertension. Some difference in women's health care can be explained related to culture, low self-esteem, lack of assertiveness, barriers, like we talked about, the financial, socioeconomic barriers, less insurance. Some women feel like, oh, I got a prescription for hydrochlorothiazide, I can't afford it. Instead, there are programs, there's cards, there's always hope. So when you're educating your patients, or when I'm educating you, and then you're educating some people in your family, it's no risk. I mean, if you want to get into a program, when you need help getting medication, there's programs, there's cards, there's discount rates. You can get them shipped to you for cheaper. You can go. Amazon even has a pharmacy that's low, right? Lower educational expectations. And we also can talk about the racism and health bias. And I know we're going to do a part 2 in this. So Tiffany, I'm going to be finished with my presentation after this, but we're going to talk about other healthcare problems when it comes to women's health. And last but not least, before I go, I want to talk about the hormones. A lot of women after 40, 45 start experiencing premenopause, perimenopause, menopause, postmenopause. Hormones protects your heart against heart disease, but after menopause, there may be or may not become a more risk. Why do we say that? Because research is out, and maybe Ms. Carly can elaborate on that. But research is out saying sometimes hormones increase. It does protect against your heart, but then after a certain age, it increases your breast cancer risk, which is, the jury is still out, in my opinion, as a healthcare provider. But all that plays a part in being cardioprotective. And that's the biggest thing. Cardioprotection, decreased hypertension, which will decrease the morbidity and mortality in Louisiana from women from heart disease and hypertension. So with that being said, I want to say thank you guys for allowing me to talk about hypertension. I want you guys to take my and I'm done, Tiffany, you can let me go. Take my information, leah.cullins@la.gov. And anything you guys would like to email me that you may have not touched or you'd like to elaborate on, feel free to email me at any time. So leah.cullins@la.gov. Thank you for your time, and we'll take answers at the end.
Thank you so very much, Dr. Cullins, for that informative information. At this
Thank
time, you are welcome. At this time, we will have our final keynote speaker for today, and that is Carly Baudouin. Carly Baudouin is the Assistant Director for the Louisiana Cancer Prevention and Control Programs at LSU Health New Orleans School of Public Health. She has over a decade of experience in public health, with most of her work focusing on cancer prevention and control and chronic disease management. Carly holds a Master of Public Health from Tulane University's School of Public Health and Tropical Medicine. Without further ado, let's give a great big virtual round of applause for Carly Baudouin.
Thank you so much, Tiffany, for the introduction, and thank you, Well Ahead, for inviting me to present today. I'm excited to be here to talk about cancer screening and early detection for women. It's such an important topic to discuss because, as Dr. Cullins said, cancer is the second leading cause of death among women in Louisiana after heart disease. And cancer has such a personal impact on our lives. I think it's safe to say that everyone on this call has been touched by cancer in one way or another. Today, I'm going to focus on breast, cervical, and colorectal cancer. These are cancers that we know we can prevent or detect early and effectively treat or cure. Okay, next slide, please. I have a lot of information to cover today, and I know we have audience members today who come from diverse professional backgrounds, and I hope that everyone takes something away from this presentation that is useful for you in your work. So I'm going to start by going over an overview of the Louisiana Cancer Prevention and Control Programs, or LCP. I'll look at the burden of cancer in Louisiana, screening recommendations, risk factors and symptoms, evidence-based interventions for cancer screening, and then I will spotlight a couple of the programs within LCP. Next slide, please. Let's get started by talking about the Louisiana Cancer Prevention and Control Programs. We're a CDC-funded program with the mission of eliminating suffering and death in Louisiana by focusing on cancers that can be prevented or detected early and cured. We have 3 flagship programs in addition to various research projects and initiatives. One of our programs, the Louisiana Comprehensive Cancer Control Program, provides ongoing cancer surveillance, partnership development, and support for the development and implementation of programming for multiple cancers along the cancer continuum. The Louisiana Breast and Cervical Health Program provides low-income, uninsured, and underinsured women across the state with access to timely breast and cervical cancer screening and diagnostic services. And then lastly, we have the Screen Up program, which facilitates quality improvement efforts to increase screening rates for breast, cervical, and colorectal cancer in clinics across Louisiana. So on this slide, you'll see a timeline of our programs, which began in 2001 with the establishment of the Louisiana Breast and Cervical Health Program at LSU Health New Orleans. Next slide, please. In the next few slides, I'll talk about the burden of breast, cervical, and colorectal cancer among women in Louisiana. This will lay the foundation for the rest of my presentation. So let's start off with breast cancer. As you can see on the right, there are several different kind of graphics. These come from the Louisiana Tumor Registry. They have a dashboard. It's very user-friendly. You can go and pull not just these 3 cancers, they have other cancers as well that you can look at. So actually, our screening rates in Louisiana for breast cancer are pretty high. 70% of women in Louisiana had a mammogram in the last 2 years. But breast cancer is the second leading cause of cancer death in Louisiana. And Louisiana ranks 4th in the United States for cancer deaths. As you can see in the deep purple areas on the map of Louisiana, these are the areas with the highest death rates in the state. These parishes include Sabine, Natchitoches, Vernon, and Rapides Parish, with a few outliers throughout the state. Across all 3 cancers, we see major disparities, and breast cancer is no exception. African American women are significantly more likely to get and die from all 3 cancers than their white counterparts. Next slide, please. And just a note before I continue about the QR codes on these 3 slides will take you to a 1-pager on each of the cancers. So as you can see, for cervical cancer, we also have pretty high screening rates. 78.1% of women had a Pap test in the last 3 years. Louisiana ranks 11th in the United States for new cases of cancer and 5th in deaths. However, Louisiana ranks 2nd in deaths among African American women. Cervical cancer is a cancer that no woman should die from. It's preventable with HPV vaccination and regular screening, and very treatable if it's found early. Next slide, please. Okay. Colorectal cancer. 72% of women in Louisiana met the recommended screening guidelines for colorectal cancer. As a state, we're going for 80%. So I think, over the next 5 years, we have a shot of getting there. Louisiana ranks 5th in the US for new cases of colorectal cancer among women and 6th in deaths. And it's the 3rd leading cause of cancer death among women in Louisiana. So you can see there are several areas of deep purple. So these are areas with the highest death rates. These graphics on the right are overall men and women. Unfortunately, the dashboard doesn't separate out for colorectal cancer by men and women. So you can see these dark areas, regions 4, region 6, definitely have among the higher rates of colorectal cancer in the state. And of course, there are some outliers throughout the state. Next slide, please. Okay, so next we're going to take a look at screening recommendations. Next slide. So first, looking at breast cancer, in April of this year, the United States Preventive Services Task Force released a new screening recommendation for breast cancer. So in recognition of the rising rates of breast cancer in younger women, they now recommend all women begin screening at age 40. And women should be screened every other year, beginning at age 40 to age 74. Women who have a family history of breast cancer should really be having these discussions with their provider because screening may be indicated at an earlier age. And certainly if any woman is experiencing symptoms of breast cancer, and I'll talk about those on the next slide, that would be a reason to talk to your doctor right away. Colorectal cancer screening that is recommended beginning at age 45 to age 75 for average risk adults. This screening recommendation was also changed in the past couple of years, recognizing the rising rates of colorectal cancer in younger people. There are 3 tests that are recommended for average risk adults. Those are stool-based tests, which are also called FIT tests. You've probably heard of it referred to that. Those are recommended annually. There's also a stool DNA test. The only test on the market is Cologuard, which you've probably seen commercials for. That's every 3 years. And then colonoscopy, which is still recognized as the gold standard. It's recommended, the recommendation is every 10 years, depending on the results of your colonoscopy. That may change the frequency with which you need to get it. And so there are 3 options, and there are many factors that may go into which test you choose. There are definitely pros and cons of each test. But as we like to say, the best test is the one the patient will get and follow through with. So if you're in a rural area and you have a patient that's average risk, it may be a good option to go with one of the stool-based tests, something that's easy and you can do it at home. So before age 45, if you have a family history of colorectal cancer or a family history of polyps, colorectal polyps, you should really talk with your provider about that because you may need to get screened before age 45. So with both breast cancer and colorectal cancer, knowing your family history is so important. Those will drive a lot of the decisions around when to begin testing and the conversations that you have with your provider. So lastly, I'll discuss cervical cancer screening recommendations. Screening is recommended beginning at age 21. From age 21 to 29, the recommendation is for a Pap test every 3 years. From age 30 to 65, there are a few testing options. A Pap test every 3 years, co-testing, so that would be a Pap test with an HPV test every 5 years. And then you can also do high-risk HPV testing alone every 5 years. And the FDA actually in May this month approved a self-collection option for HPV testing. For now, it will only be available for in-clinic use. There are a lot of trials ongoing around HPV self-collection. So once those trials have concluded, I think we'll see different recommendations around self-collection. Okay, next slide, please. I'm sorry, just to note, all of those recommendations come from the United States Preventive Services Task Force. There are other recommending bodies, and I think depending on which one you look at, you'll probably see a slightly different recommendation. But as a CDC-funded program, we our work is guided by the United States Preventive Services Task Force recommendation. Okay, so risk factors and symptoms. Next slide, please. So I won't go into all of them because they're not even all listed here for risk factors and symptoms, but I'll just highlight a few of them. So for breast cancer, there are certain genetic mutations that may put you at greater risk for breast cancer, BRCA1 and BRCA2, namely. Having dense breasts, that can make it harder to see lumps during a mammogram. And then reproductive history. So that would be starting your menstrual period before age 12 and starting menopause after age 55. That's because it exposes you to hormones for a longer period of time. Family history, of course, I mentioned that's another key factor. And then lifestyle factors, similar to the lifestyle risk factors for heart disease, they're pretty much the same for breast and colorectal cancer. Smoking, alcohol use, diet, physical activity. These are all modifiable risk factors for both colorectal and breast cancer. Symptoms, the most common one you hear about is feeling a lump. You could also have some dimpling or irritation or redness on the breast, pain, of course. Having discharge from the nipple would be potentially a symptom. Colorectal cancer, some of the most common risk factors are having an inflammatory bowel disease, having a personal or family history of colorectal cancer or colorectal polyps, having a genetic syndrome like Lynch syndrome. And then, of course, we know for colorectal cancer, lifestyle factors potentially play a very big role. There are many symptoms for colorectal cancer, but having blood in your stool would be common. Having pain, having just bowel habits that are unusual for you, that would be something to talk with your provider about. And then cervical cancer, the biggest risk factor is having an infection with HPV. It accounts for almost all cases of cervical cancer. Other risk factors are sexual history, smoking, having a weakened immune system. So like having an HIV infection may put you at greater risk for cervical cancer. Cervical cancer early on is likely to have no symptoms, and that's why it's so critical to get your regular screenings. And then if you are experiencing symptoms like abnormal bleeding or discharge, pain, particularly after sex, that would be potentially a symptom, but it would be at probably a later stage for the cervical cancer. So really, there's no reason why a woman should die from cervical cancer. There is a vaccine that prevents cervical cancer. In fact, in Scotland, they have found that in young people that they have vaccinated, no cases of cervical cancer. So it's truly preventable. And then with regular screenings, they can find issues before they develop into a bigger problem. So again, really a cancer that we can probably eliminate. I think if everybody worked together, this would be a cancer we could eliminate in Louisiana. Next slide, please. Okay, so I'll just touch on these briefly. These are some of the evidence-based interventions for cancer screening. Next slide, please. So these are interventions that are recommended by the community guide. And I've got the website there. You can also scan the QR code after the presentation and to get kind of a full list of all of them, and you can read a little bit more. But breast, cervical, and colorectal cancer client reminders are an evidence-based intervention, or I'll just say EBI for brevity. And those can be postcard, email, text, basically any written reminders to the client. Reducing structural barriers. So that could be offering hours in the evening, extending clinic hours, weekend hours, offering services in an alternative setting like a mobile mammography unit. And then, really helping patients overcome some of the barriers like around scheduling, translation services, transportation, things like that. Next slide, please. And then community health workers and patient navigation in 2022, the community guide recognized these as evidence-based interventions for all 3 cancers to promote screening for all 3 cancers. For community health workers, if they're doing, education, one-on-one education. Okay, thank you, 3 minutes. Client reminders, small media, and then patient navigation, also, client reminders and reducing structural barriers. Next slide, please. Okay, I'm going to go through these quickly. Next slide. Okay, the Louisiana Breast and Cervical Health Program, I already talked about the mission of it. We provide no-cost tests to uninsured and low-income women in Louisiana. Next slide, please. This is the eligibility criteria for cervical cancer, ages 21 to 64, breast is 40 to 64, income is at or below 250% of the federal poverty level. You can see we offer mammograms, HPV and Pap tests and diagnostic tests, in addition to patient navigation services. Next slide, please. These are our locations. We are across the state. We have a couple of providers that offer their services via mobile unit. So that would be like Women's Hospital and Partners in Wellness at LSU HSC Shreveport. Next slide, please. You can make online referrals to our program by visiting lbchp.org. Scanning the QR code will take you directly to our referral form. It's very easy. It just asks a few key questions so that we can follow up with patients and have some of the preliminary information we need. Next slide, please. Okay, Screen Up. Screen Up works with primary care systems and health systems to implement evidence-based interventions. So by using these evidence-based interventions or strategies that have been proven to be effective, clinics can improve the quality and rate of cancer screenings, which reduces healthcare costs and saves lives. Next slide, please. So these are the evidence-based interventions that the program implements. There are provider-focused interventions like provider reminders and provider assessment and feedback, patient-focused interventions. So that includes patient reminders and reducing structural barriers. We talked about both of those. And then there are several supporting activities that clinics can implement. Next slide, please. And this is just a look at how the program measures success. For colorectal cancer, it's the screening rate, the return rate for FIT kits, and colonoscopy completion. And then for EBI, for breast and cervical, it's the number of patients screened and the number of patients eligible for screening, along with how they implement the EBI indicators. Okay, and then these are a couple of reports that we develop. You can find them on our website. We have the Louisiana Comprehensive Cancer Control State Plan, and then we also recently released our 2023 Impact Report. All right, that's it. Thank you so much.
Thank you so very much, Carly, for that informative presentation. We appreciate you joining us today. Now it's the time we've all been waiting for. We have reached our Q&A segment of today's presentations. And I will allow both keynote speakers, Dr. Cullins and Carly, the opportunity to answer any questions that we do have in the chat on today. We do have an initial question, and I will direct this to Carly. When you have dense breast and a family history of breast cancer, is there a more specialized or in-depth breast exam that can be requested for the annual exam?
As of now, although I think there may be some legislation out there to offer different screening modalities for women for insurance to reimburse for them. But I would think, and And if there's a provider, I'm not a clinician, but if there's another provider on the phone that would like to chime in, I think that they would probably start with a regular screening mammogram.
Okay, thank you. Dr. Collins, did you want to add to that?
Yes, I want to add, Ms. McCall is right. They'll start off with a screening mammogram, and if they find any abnormalities, then they'll call you back and do a 3D mammogram. Yeah. So if you find abnormality, I mean, they're on it, and they'll call you within, for like, if it's something abnormal, one, like say on a Thursday, they'll call you to be scheduled to get that 3D on by that Friday. Like, they're on it. So yeah.
Thank you all, and I will ask this next question for both presenters, and I will allow Dr. Collins to go first. Can you all discuss some of the key health promotion recommendations to improve care, enhance quality of life, and prevent complications? I know you both covered that a little bit in your presentations, but if you wanted to elaborate more, you have the opportunity to do so now. Dr. Collins?
Something that I want to really, and it's something I'm very, very adamant with my patients, especially my female patients, because usually the women are they make all the decisions in the household. A lot of women are single parents, and so they aren't taking care of themselves as they should, right? But I advocate for making sure you make your doctor's appointments. I advocate make sure you're drinking your water. I advocate making sure you are eating properly. But the most top two is that holistic approach. Like, you have to take some time out to de-stress. You know, you have to take some time out to eat better and exercise. Those are non-negotiables. Even if you start off slowly, like maybe you're used to having a bread and adding salt to your. I know a lot of people get plates and won't even taste good and just add salt. Decreasing your salt intake, exercising, and de-stressing, whether it's walking, meditating, listening to your favorite song, going to sit in your car and cutting your radio on during lunch, doing something for yourself. Because if you're not a service to yourself, how can you pour out of an empty cup to anybody else in your family, your friends, or your coworkers? So take care of yourself. Easier said than done. But if you start off small, then work on something big, and you'll see positive effects.
Thank you so much, Dr. Collins. Carly, did you want to add to that?
I would say as far as in the community, you know, as you're out in the community, really prioritizing areas that have patients who are or people who are disparately impacted by these cancers. So really using data to inform and drive, you know, where you're targeting your outreach efforts. Educating people about their risk for cancer. And we know that one of the best indicators of a successful screening completion is that strong provider recommendation. So, you know, working with providers and clinics to ensure that, you know, they're implementing interventions to recommend and follow up with patients on screening recommendations.
Thank you so much. And we do have one last and final question here. What are some of the best ways to help manage blood pressure and women's health in workplace settings? And I will turn to you, Dr. Collins.
I'm sorry. I was on mute. I apologize. First thing I recommend is you got to management. First, you got to identify it as being a problem, right? I'm a firm believer. I don't want you to just guess what your blood pressure is when you come in to see me as a provider. I want you to be able to have a journal. So write down your blood pressure, you know, and see what causes spikes in. Oh, my head is hurting so bad. My head is hurting so bad. Why my head is hurting? Check my pressure. My pressure's up. What caused those? What caused those abnormalities? Was it stress? Was it something you eating, or is it just something going on physiologically with your body? Keep an ongoing journal. Even if you have to put it in your notes in your phone. I know we don't carry around, but put in your notes in your phone with the dates. Keep an ongoing track so when you get to your healthcare provider, you're able to explain, okay, I had a headache this day. Well, was it caused by stress? No, I was off. Okay, was it caused by eating? No, I didn't eat anything. Ways we can get to the root problem. If we're running track of what's going on, there's no way we can pinpoint what's going on. Does that make sense?
Yes, thank you so much, Dr. Collins. Carly Boudouin, would you care to expatiate or expand on that? The question is, what are some of the best ways to help manage blood pressure in women's health in workplace settings?
I would say, encouraging employees to get screened, making sure they're aware of the screening recommendations. Encouraging, we all have sick time available to us. I think most of us on here are state employees. So, taking advantage of that and scheduling those screenings is really important. And, I think too, as employers, modeling that behavior, that you're taking care of yourself, that you are prioritizing your own health, really could potentially have a trickle down effect to your staff, when they see that, you're going and seeing your doctor and you're, getting your cancer screenings.
And I want to piggyback on what Carla said. Also encouraging your coworkers. They see you're taking care of yourself, and you're just having discussion. Encourage them to do the same.
Absolutely. Thank you so much, Carly and Dr. Cullens. Are there any more questions from our attendees and participants this afternoon? I do not see any currently in the chat. Thank you all so very much for those wonderful presentations. Very empowering, very impactful, Dr. Cullens and Carly. And without further ado, we will move on to our closing remarks for today's presentation. Now we will hear from our Bureau Director, Ms. Avis Richard.
Absolutely, Tiffany. This has been two wonderful presentations, very resourceful and helpful information for women's health especially. I do want to share with those of you who are in the Bienville building, we will be scheduling hypertension screening soon. So definitely be on the lookout for information that will come out in LDH today, and also through the email link, the DHH entire. Again, I can't say enough about the presentations. They were phenomenal. And Tiffany, if I'm correct, we will share these presentations with the group. Is that accurate?
Yes.
Awesome. Thank you all for joining us today. We certainly appreciate having you on this webinar. And stay tuned, because we will continue our monthly webinar series to help improve chronic disease outcomes in our state, and especially among our employees. Thank you all.